Good morning, everyone. Today we'll be discussing a case that we managed in our NICU. So this baby was born to a Gravida 3 mother. The mother had the following antenatal risk factors during her pregnancy: gestational hypertension, gestational diabetes, and mild polyhydramnios with an AFI of 26 detected in the third trimester. Antenatal screening tests were done, which were normal. Both the NTNB and dual screen as well as the level 2 screen were normal and revealed no gross congenital anomalies. The mother underwent an emergency LSCS at 34 plus 3 weeks of gestation, and the indication for the same was severe preeclampsia. At birth, the baby had a normal transition from intrauterine life and did not require any resuscitation. The baby cried immediately at birth. Delayed cord clamping was done. However, at 1 hour of life, the baby was noted to have respiratory distress with a Silverman Anderson score of 3 by 8, and frothing from the mouth was noted. Delivery room CPAP was initiated for the same, and an OG tube was tried to be passed for feeding, but it was observed that the tube did not go beyond 10 centimeter, and there was a definitive resistance felt on trying to pass the OG tube. With a suspicion of esophageal atresia, the baby was kept NPO, and the chest X-ray was ordered immediately. On doing the chest X-ray, it was observed that there was coiling of the OG tube in the upper thorax, which is of a very textbook representation of esophageal atresia. He also observed that the bilateral lung fields were clear and bile gas was present, suggestive that the distal esophageal is connecting with the trachea because air is present in the bowels. This led us to a diagnosis of a tracheoesophageal fistula type C. Tracheoesophageal fistulas are divided into 6 types based on the Gross classification. In the first type, there is complete esophageal atresia and no connection with the tracheobronchial tree. In the second type, the B type, there is the proximal esophagus is connecting with the tracheobronchial tree, and there is distal esophageal atresia. In the type C, which was present in our patient, there is a proximal esophagus which is atretic, and the distal esophagus connects with the tracheobronchial tree, and hence bile gas would be present. Type D is characterized by both the proximal and the distal esophagus connecting with the tracheobronchial tree separately. Type E or the H type, where the complete esophagus is patent, but there is a common connection with the tracheobronchial tree. And type F is where there is only stenosis of the esophagus. Type C is the most common type of esophageal atresia and can be present in about 70% cases of tracheoesophageal fistula and esophageal atresia spectrum. In our patient also, he had a type C kind of tracheoesophageal fistula. So further, another chest X-ray was done by passing the red rubber catheter. This has surgical implications as it helps the surgeons to delineate where the proximal esophageal stump is ending. If the proximal esophageal stump is ending very proximal in the upper thorax, that may point towards a high tension anastomosis being needed in the surgery, and that will have both prognostic as well as therapeutic implications, as we will later see. Thus, it is important to do a chest X-ray with a red rubber catheter to delineate where exactly the proximal stump is ending. So, preoperative management. The baby was kept NPO. Feeding was not tried in this baby, as soon as the OG tube was tried to be passed, we had suspicion of an esophageal atresia, so we did not try feeds. The baby was started on total parenteral nutrition, and continuous oral suctioning was done by keeping a feeding tube in the oral cavity at a pressure or at a negative pressure of 10 to 12 centimeter H2O. This was done to relieve any secretion that may be present, so that to minimize the risk of aspirations. Associated anomalies were checked for. An infantogram was done, a USG KOB was done, which both were normal. 2D echo was also done and was normal. This was very important as 2D echo is required pre-operatively to see if there are any cardiac conditions that may be a contraindication to the surgery the patient will require. Also, there were no anorectal malformations present. The baby was operated on day 2 of life. So next we'll observe what were the findings during the intra-op bronchoscopy, which was done just prior to performing the surgery itself. So in this video we can see clearly that there is a fistula which is present connecting with the esophagus with the tracheobronchial tree. Here we see the carina with the left and right bronchus, which were also filled with mucus plugs, and this is the fistula opening into the trachea. This is the intra-op finding. The arrow represents the upper dilated end of the esophagus. So the baby underwent primary repair with a tension-free anastomosis. The gap between the upper and lower ends was found to be just 1 centimeter. So a tension-free anastomosis was done via right posterolateral retropleural thoracotomy approach, and the baby was shifted back to the NICU post-op. The plan was to keep the baby electively intubated for 24 hours. The baby was to be kept nil per oral for 48 hours, and ICD would remain in situ, and minimum neck movements would be done. All of this was pre-decided based on the tracheoesophageal fistula protocols which were in place. The further plan was that after 48 hours we could start feeds through the NG tube. However, there should be no manipulation of the NG tube and there should be minimum neck movements. A contrast study would be done at day 7 to assess for any anastomotic leak. If there was no leak, we could remove the OG and the ICD and start the baby on oral feeds. However, if a major leak was present, that would be an indication for an immediate diversion surgery. Coming to the post-operative events, on day 5 we observed that the baby had a new onset worsening in the respiratory distress, and there was a thick yellow-white discharge which was coming out from the ICD associated with decrease in the column movement. We explored the ICD site and a thick loculated collection was found with a similar yellow-white discharge coming out of it, and on exploring, around 20 ml of fluid was drained. As we can see in this picture, from the ICD side there is exudation of thick yellow-white fluid. The ICD was reinserted following exploration, and there was column movement present thereafter. Chest X-ray was done, which showed a localized pleural effusion on the right side, as we can see here. And another observation which we made was that the abdomen was completely gasless. So at this stage our possibilities were of an anastomotic leak. Since the baby had been started on feeds, the leak could explain the right-sided pleural effusion as well as the gasless abdomen. The second possibility was that of a chylothorax. Thoracic duct injury is a known complication of TEF surgery and could lead to a pleural effusion with draining of a thick white fluid, which may have been lymph. We did send the drain fluid for a biochemistry examination, but the fluid was found to be too viscid for any kind of laboratory investigations to be done on it. The third possibility was infection, and the drain culture, we had sent the drain fluid for culture, which actually grew Enterococcus fecalis. Antibiotics were upgraded appropriately for the same. Because of the primary possibility of a leak, a contrast study was performed, and we'll see now what the contrast study showed us. So we see very clearly in this contrast study that there is a major leak present. As soon as the contrast reaches the upper esophagus, there is a leak into the pleural space and the mediastinal space, confirming a diagnosis of a major leak. Because of the major leak, the baby was immediately taken up for diversion surgery. Anastomotic leak is a common immediate post-op complication of tracheoesophageal fistula and esophageal atresia surgery and can occur in up to 17% cases. Although minor leaks can be managed conservatively, major leaks such as what occurred in our baby require immediate diversion surgery. So our baby underwent cervical esophagostomy and gastrostomy. Intra-op, the findings were that the distal esophagus was found to be, the end was found to be very friable. Thus, to preserve the integrity of the distal esophagus and allow time for healing, the baby was kept NPO for 7 days. Gastrostomy feeds were started on post-op day 7, which the baby tolerated well, and the baby is currently on full enteral feeds through the gastrostomy tube. We are currently training the parents in giving gastrostomy feedings. So post the diversion surgery, the story did not end. The baby did have further complications in the form of that we observed after extubation that the baby had inspiratory stridor, which we'll observe in this video. There is a prominent inspiratory stridor which is associated with prominent subcostal retractions. This points us towards an extrathoracic obstruction. So among stridor, if we see whether we can differentiate whether the obstruction is extrathoracic or intrathoracic based on when the stridor is appearing. During inhalation, because of the negative pressure generated in the thoracic cavity, there will be compression of the extrathoracic airway, but the intrathoracic airway will dilate because of the lung parenchyma dilating and splinting the intrathoracic airway. Thus, any extrathoracic obstruction, there would be stridor present on inspiration because of the negative pressure. Vice versa, during exhalation, because of the positive pressure generated within the intrathoracic cavity, there is collapse of the intrathoracic airways. Thus, any intrathoracic obstruction would have expiratory stridor because of collapse of the airways and decrease in the caliber of the airways because of the positive pressure in the intrathoracic cavity. Thus, if the baby is having inspiratory stridor, that points towards an extrathoracic obstruction. Expiratory stridor points towards an intrathoracic obstruction. Our baby had prominent inspiratory stridor with prominent subcostal retraction, which pointed us towards an extrathoracic obstruction. So the possibility is kept for post-extubation stridor, and a fiber optic laryngoscopy was done for the same, which was suggestive of vocal cord edema, which actually supports our diagnosis of post-extubation stridor. The baby was managed with dexamethasone given for 4 doses and adrenaline nebulizations, and following that there was significant improvement in the stridor. This is about 5 days post therapy, which was dexamethasone. We observe in this video that there is minimal stridor present. We also kept other possibilities such as a vocal cord palsy, which is a known complication of TEF surgery. However, the baby did have significant improvement with the dexamethasone and adrenaline nebulizations. So, antenatal diagnosis of tracheoesophageal fistula is difficult to make. We may observe a small or an absent stomach bubble with or without polyhydramnios, which may be seen by 14 weeks period of gestation. However, the sensitivity for this is only 26%. Later in the third trimester, an upper pouch sign may be seen, which is the dilation of a blind end of the upper esophageal system segment. This can be identified by 32 weeks POG, but it is very observer dependent. Thus, antenatal diagnosis of TEF is difficult to be made and may be easily missed. The question arises that should an OG tube be inserted in all cases of polyhydramnios? So severe polyhydramnios is actually associated with 75% of the cases with severe polyhydramnios have some sort of congenital anomaly. So traditionally the recommendations have been that in all cases of severe polyhydramnios, an OG tube should be passed to check for an esophageal atresia. However, Hart et al. Did a study in 2016 and reviewed all the evidence that was present in the literature, and they gave a recommendation that polyhydramnios alone does not warrant invasive investigation with OG insertion. However, this was only a grade D recommendation. They also recommended that if there are additional abnormalities present or if the antenatal ultrasounds are suggestive of any gross congenital anomaly, the threshold for investigating with an OG tube should be lower. That was also a grade D recommendation. So briefly discussing the protocol for a management of a baby with tracheoesophageal fistula and esophageal atresia. There are two primary surgical options present. You can either do a primary repair, or if there is a long gap esophageal atresia present and a primary repair is not possible, we proceed immediately with an esophagostomy and a gastrostomy. If primary repair is present, and a normal anastomosis can be done, which is a tension-free anastomosis, as was done in our baby, extubation can be done on day 1. However, if a tension anastomosis has been done because of the increased gap present between the upper and lower esophageal segment, extubation is only done on day 3. Post extubation, we initiate trans-anastomotic feedings 1 day after extubation, and a contrast esophagogram is done in all cases on day 7. If there is no leak present on the contrast esophagogram, the feeding tube and the chest tube is removed. Oral feeds are started and the baby is discharged on Rantac and domperidone. However, if a leak is present, the immediate diversion surgery has to be done, as was done in our baby. Esophagostomy and gastrostomy are done. Gastrostomy feedings are initiated, and esophageal replacement is done at 1 year of life. So, managing these babies in a protocolized manner leads to improved outcomes, as all complications are anticipated and they can be timely managed by following this protocol. So, babies with tracheoesophageal fistula may have several complications post-op. Immediately within the first 30 days, anastomotic leak is the most common complication observed, which was also seen in our baby. Short-term complications include anastomotic stricture and a recurrent tracheoesophageal fistula because of a missed connection. Long-term complications which occur more than 1 year after the surgery include upper respiratory tract involvement in the form of tracheomalacia and vocal cord dysfunction. In our baby, we saw that because of the prolonged intubation, there was vocal cord dysfunction present. Lower respiratory tract involvement, chest wall deformity and bronchiectasis, and GI involvement. These babies commonly suffer from esophageal dysmotility, gastroesophageal reflux, aspiration, and food bolus obstruction. These complications have to be anticipated in this baby and appropriately managed timely. So, briefly discussing the prognosis of tracheoesophageal fistulas, there have been several classifications that have been in place. We will be discussing two of them. The Spitz classification divided the babies into 3 categories based on the birth weight and the presence or absence of major cardiac anomalies. Although the Neo classification, proposed in 2009 by Okamoto, divides the babies into 4 categories based on the birth weight, less or more than 2 kgs, and the presence or absence of major cardiac anomalies. Our baby fell into the first category with a birth weight more than 2 kgs and no cardiac anomalies present, and the risk of mortality is almost 0% in these babies. In comparison, babies who are more than 2 kgs but have major cardiac anomalies have a mortality risk of 17%, and if the birth weight is less than 2 kgs and they have major cardiac anomalies, the risk of mortality rises to as much as 60%. So this was our case discussion on a baby with tracheoesophageal fistula which was managed in our NICU. Thank you all for listening.